Assalamu alaikum. Today we are going to discuss about hemostasis and related disorders. Introduction. Hemostasis. Integrity of the blood vessel is necessary to carry blood to tissues. Damage to the wall is repaired by hemostasis, which involves formation of a thrombus at the site of vessel injury. Hemostasis occurs in two stages, primary and secondary. Number 1. Primary hemostasis forms a weak platelet plug and it's mediated by interaction between platelets and the vessel wall. Number 2. Secondary hemostasis stabilizes the platelet plug and is mediated by the coagulation cascade. Primary hemostasis and related bleeding disorders. Primary hemostasis. Step 1. Transient vasoconstriction of damaged vessels, mediated by reflex neural stimulation and endothelin release from endothelial cells. Step 2. Platelet adhesion to the surface of disrupted vessel. Von Willebrand factor binds exposed subendothelial collagen. Platelet binds von Willebrand factor using the GPIB receptor. Von Willebrand factor is derived from the weeble pallet bodies of endothelial cells and alpha granules of platelets. Step 3. Platelet degranulation. Adhesion induces shape change in platelets and degranulation with release of multiple mediators. ADP is released from platelet dense granules, promote exposure of GP2B3A receptor on platelets. TXA is synthesized by platelet cyclooxygenase and released promote platelet aggregation. Step 4. Platelet aggregation. Platelet aggregates at the site of injury through GP2B3A using fibrinogen from plasma as a linking molecule. Results in formation of platelet plug. Platelet plug is weak. Coagulation cascades. Secondary hemostasis stabilizes it. Disorders of primary hemostasis. Usually due to abnormalities in platelets divided into quantitative or qualitative disorders. Clinical features include mucosal and skin bleeding. Symptoms of mucosal bleeding include epistaxis, most common overall symptom, hemoptysis, GI bleeding, hematuria, and menorrhagia. Intracranial bleeding occurs with severe thrombocytopenia. Symptoms of skin bleeding include petechiae, 1 to 2 mm, echomyosis, echinomosis, purpura, and easy bruising. Petechiae are a sign of thrombocytopenia and are not usually seen with qualitative disorders. Useful laboratory studies include platelet count normal 150 to 400 K per microliter. More than 50 K per microliter leads to symptoms. Bleeding time normal 2 to 7 minutes, prolonged with quantitative and qualitative platelet disorders. Blood smear used to assess number and size of platelets. Bone marrow biopsy used to assay megakaryocytes which produce platelets. Immune thrombocytopenic purpura. Autoimmune production of IgG against platelet antigen. Most common cause of thrombocytopenia in children and adults. Autoantibodies are produced by plasma cells in the spleen. Antibody-bound platelets are consumed by splenic macrophages, resulting in thrombocytopenia. divided into acute and chronic forms. Acute form arises in children weeks after a viral infection or immunization, self-limited, usually resolving within weeks of presentation. Chronic form arises in adults, usually women of childbearing age, may be primary or secondary, for example SLE, may cause short-lived thrombocytopenia in offspring since antiplatelet IgG can cross the placenta. Lab findings include less platelet count, often less than 50 K per microliter, normal PT or PTT. Coagulation factors are not affected. More megakaryocytes on bone marrow biopsy. Initial treatment is corticosteroids. Children respond well. Adults may show early response but often relapse. IVIG is used to raise the platelet count in symptomatic bleeding, but its effect is short-lived. Splenectomy eliminates the primary source of antibody and the site of platelet destruction, performed in refractory cases. Microangiopathic hemolytic anemia. Pathologic formation of platelet microthrombi in small vessels. Platelets are consumed in the formation of microthrombi. RBCs are sheared as they cross microthrombi, results in hemolytic anemia with schistocytes seen in thrombotic, thrombocytopenic purpura and hemolytic uremic syndrome. TTP is due to decrease ADAMTS13, an enzyme that normally cleaves von Willebrand factor multimers into smaller monomers for eventual degradation. Large uncleaved multimers lead to abnormal platelet adhesion resulting in microthrombi. Decreased ADAMTS13 is usually due to an acquired autoantibody most commonly seen in adult females. HUS is due to endothelial damage by drugs or infection, classically seen in children with E. coli. O157H7 dysentery, which results from exposure to undercooked beef. E. coli virotoxin damages endothelial cells resulting in platelet microthrombi. Clinical findings HUS and TTP include skin and mucosal bleeding, microangiopathic hemolytic anemia, fever, renal insufficiency, more common in HUS. Thrombi involves vessel of the kidney. CNS abnormalities, more common in TTP. Thrombi involves vessel of the CNS. Lab findings include thrombocytopenia with more bleeding time, normal PT or PTT, coagulation cascade is not activated, anemia with schistocytes, more megakaryocytes on bone marrow biopsy. Treatment involves plasmapheresis and corticosteroids, particularly in TTP. Qualitative platelet disorders. Bernard-Sollier syndrome is due to a genetic GPIB deficiency. Platelet adhesion is impaired. Blood smear shows mild thrombocytopenia with enlarged platelets. Glanzmann thrombasthenia is due to genetic GP2B3A deficiency. Platelet aggregation is impaired. Aspirin irreversibly inactivates cyclooxygenase. Lack of TXA2 impairs aggregations. Uremia disrupts platelet functions, both adhesion and aggregations are impaired.